Thank you for joining this Specialty Pharmacy Times peer exchange, which discusses the optimal utilization of oral oncolytics. I'm Dr. Peter Salgo, Professor of Medicine and Anesthesiology at Columbia University College of Physicians and Surgeons, and Associate Director of Surgical Intensive Care at New York Presbyterian Hospital. Joining me with this distinguished panel are Dr. Noa Biran, medical oncologist at the John Theurer Cancer Center at Hackensack University Medical Center in Hackensack, New Jersey; Stephen D'Amato, pharmacist and executive director of New England Cancer Specialists in Scarborough, Maine; Dr. Carl Henningson, a medical oncologist at Regional Cancer Care Associates in Freehold, New Jersey; Dr. Arturo Loaiza-Bonilla, Chief of Medical Oncology and Medical Director of Research at Cancer Treatment Centers of America in Philadelphia, Pennsylvania. You know, the American Cancer Society estimates that approximately 1.7 million new cases of cancer will be diagnosed in the United States in 2017, and more than 15 million Americans are living with a history of cancer. In 2014, nearly 87.9 billion, by the way, that's billion with a B, big number. That amount of money was spent on cancer-related care. Prescribed medication accounts for approximately 12% of the cost. Oral oncolytics account for 25 to 35% of the oncology pipeline. These drugs offer patients another option in their cancer treatment. Throughout this panel discussion, we're going to explore clinical and economic considerations surrounding the use of oral oncolytics, and we're going to look at strategies for optimally managing cancer with these drugs. So I want to thank you for joining us. All you guys here, thank you for joining us as well. Why don't we get going in here? Some of the numbers that I was looking at here are simply astounding. $87.8 billion. That's a lot of money, even for the federal government. Spent on cancer-related health care, right? This is from the American Cancer Society. And prescribed medications, about 12% of these costs. Why so little, I guess, or is that a lot? Where do we go from here?
I think 12% is about right. I think when you look at the clinical and economic burdens today, as my colleagues here know, the treatments have become much more complex. Not only is it just the treatments that we have to deal with, but certainly the prior authorizations that we all have to go through administratively. Now we have personalized medicine with genomics and molecular testing that further complicates that. And with the oral agents, certainly expanding options for our patients, but at an economic burden. When you look at the out-of-pocket expenses that our patients now have for some of these agents, it can be in the thousands, tens of thousands of dollars, which makes access sometimes difficult to get these.
You know, I'm glad you put it on an individual basis. If you take a look at 12% of close to $90 billion, well, we're in there in the $9 billion range. But in terms of an individual, that's thousands. And many, many people don't have that kind of resources. And they're going to count on their insurance, right? I mean, does insurance cover all this? We're going to get into the specifics later, but...
Well, insurance may cover some of those costs, but unfortunately right now we're in this era of like cost sharing between the payer, even the providers and the patients. So really a lot of financial toxicity is coming, and we need to understand how to overcome those challenges as we want to look forward with these drugs, as more and more are coming for the personalized medicine approach.
Did you catch that term? Financial toxicity?
It's real.
It's real, isn't it?
It's real.
I mean, in some ways, you know, you're looking at a financial impact just as you're looking at an anatomic impact from a tumor. This is nasty stuff. Now, the oral oncolytics, and we're going to be focusing on them to some degree, they're what, about 25, 30% of all the new drugs in the pipeline? Is that an increase, decrease, stay the same, what?
It's definitely increasing. I mean, a lot of our new drugs are oral oncolytics, and you know, one of the issues and why it's starting to contribute a lot to the cost is that people are living longer and longer with these new treatments. So, for instance, with CML, patients used to die in between 3 and 5 years. Now with these new drugs, they're expected to live, 20, 30 years, and the population of CML is increasing because of that, and the cost is rising exponentially.
I'm going to use your analogy because it occurs to me listening to you, what we're seeing is that the disease-related toxicity is going down, and as a consequence, the therapeutic-related toxicity is going up. I don't mean side effects, I mean financial.
Right.
right? So be careful what you wish for. Making people healthier costs money.
Yeah, I mean, in multiple myeloma, there are so many options for treatment, and it's not always clear which one prolongs survival or remission. But now we're looking more and more at quality of life, financial burden, cost, and these types of things to determine which treatment to give when, to determine sequence of therapy and whether or not patients should receive therapy, because all of the treatments are good in terms of outcomes and efficacy outcomes, but what's better in terms of quality and financial outcomes? That's the question, and even the FDA is starting to ask these questions in order to get drugs approved.